Now, what are different blocks? Where you can have different type of blocks. Yes? हाँ, AV blocks हो सकता है, bundle branch block हो सकता है, और and what else? We can have fascicle blocks. Now let's see this case vignette. A 70-year-old male presented with episodes of lightheadedness for last few weeks. Today he had a fall and sustained mild injury on his elbow. The attendant reported that his face turned pale and he was conscious when he was assisted to move to bed. What has happened? Patient has a syncope. This is a fit or there is a faint. What is this? This is a fit or a faint? This is a faint. The face turned pale. Patient had episodes of lightheadedness, and when the patient was taken to the bed, patient was conscious. Now, this is his ECG. What does this show? Yes? Why? Bundle branch block. Bundle branch block, what's the definition of bundle branch block? The QRS has to be more than 12 broader than 3 small squares of 120 milliseconds. So the QRS is not broad. The P wave is there. It's coming from the sinus node. Why AV nodal block? Where is the conduction? Where is the PR interval is belonging? What you want to tell is the Venke-back phenomena you are talking about. This is not Venke-back, we'll see in our lecture later on. This is 6 sinus syndrome, sinus bradycardia with a sinus pause. There's a sinus pause in between. This is 6 sinus syndrome you were talking about. So the first problem you can have is abnormal firing of the SA node. It becomes sick, fibrosed or inflamed. It does not fire properly. 6 sinus syndrome is chronic dysfunction of the SA node. Patient has chronic severe sinus bradycardia. There may be sinus pauses, there may be sinus arrhythmia, and there may be complete sinus arrest. May not be firing any impulse. Then you may have different rhythms. What is the tissue which takes up after the sinus node is? So it may be atria or the AV nodes. Progressive development of atrial arrhythmias like atrial fibrillation, atrial flutter, atrial tachycardia. Patients are usually elderly and present with lightheadedness or syncope, but it can also manifest as angina, heart failure, and palpitations. So these may be presentations. About 50% of people with 6 sinus syndrome also display some degree of dysfunction of the AV node as well, because this is generally a degenerative disorder. When there is a degeneration in the SA node, there may be degeneration in other parts of the heart as well. So it may be degeneration in the AV node as well. The etiologies are fibrosis, atherosclerosis of the sinus node artery, congenital heart disease, excessive vagal tone, some of the drugs which can slow down the SA node, familial condition because of this SCN5A mutation, infiltrative disorders, pericarditis, Lyme disease, hypothyroidism, and rheumatic fever. So these may be the reasons for 6 sinus syndrome. Now we see the patients who are relatively younger and they present with 6 sinus syndrome, you should look into these. Now another case, a 40-year-old male is being evaluated for insurance purposes. Patient is asymptomatic, general examination was normal. What is visible on this patient's ECG? Now what do you see on this ECG? G? Inversion of what? QRS complex is downward. It may be downward in some of the leads. So you see a long PR interval. You see pretty long PR interval. This is first degree heart block. Prolongation of the PR interval, which is constant, all P waves are conducted. So this is first degree AV block or first degree heart block. So in first degree heart block, all impulses which are generated at the SA node, they are conducted through the AV node. So none of them is blocked. So each P wave will have a following QRS complex. But the PR interval is long. It's more than 200 milliseconds, you call it first degree heart block. PR interval greater than 200 milliseconds. All sinus impulses reach the ventricles. Patients are generally asymptomatic. Excessive delay sometimes may cause patient to feel dyspnea if the heart is compromised, if the LV is compromised, they may have dyspnea. Weakness or dizziness, structural disease of AV node, high vagal tone, beta blockers, calcium channel blocker, digitalis, they can all cause first degree heart block. Prognosis poor in patients who got heart failure, otherwise it may not be a problem. And you see, as you mentioned, the athletes may have a slow heart, they may have first degree heart block. So the prognosis in these patients are generally very good. It's only patients who got structural heart disease, particularly if they develop advanced heart failure, the prognosis may not be good. Otherwise, this condition doesn't cause any problem. You don't need any treatment for this condition. Now, 60-year-old male presented with fever, joint pain, skin rash, lightheadedness. A diagnosis of Lyme disease was confirmed. What is Lyme disease? Borrelia burgdorferi. It causes fever, joint disease, cardiac involvement, and may involve the nervous system as well. So what is this ECG? Second degree heart block with 2-1 conduction. 2 P waves, it's not working. You can see here 2 P waves and then 1 QRS complex. Can you appreciate? You can see in the second last complex there are 2 P waves and there is a QRS complex. So the patient is having second degree heart block. This was ECG taken at Services Hospital. Some of the impulses they cross the AV node, others they do not cross the AV node. In first degree heart block, all of them cross. In second degree heart block, some impulses cross the AV node, the others do not cross the AV node. It can be asymptomatic. Patient may have palpitation, weakness, lightheadedness, syncope. On examination, patient may have bradycardia, regularly irregular heart rates. So it's different from that irregularly irregular heart rates. It may be a regularly irregular heart rate. Second degree heart block is of how many types? It's of 2 types. Good. Now what is this you were very interested in? This is Venke-Back, Mobitz type 1 or Venke-Back. There is progressive increase in the PR interval till a beat is missed. So this is Mobitz type 1 or it's called Venke-Back phenomena. And then you got the second ECG which is showing constant PR interval with intermittent failure to conduct. This is Mobitz type 2. So you may have 2 P waves, 1 QRS complex, 3 P waves, 1 QRS complex. So generally it is 2-1, 3-1 blocks. This is a little more serious than the Venke-Back phenomenon. Mobitz 1 is because of the high vagal tone, degenerative disease of the AV node blocking drugs, Lyme disease, myocarditis. Mobitz type 2, his Purkinje system deterioration, coronary artery disease, valvular surgery, myocarditis, infiltrative diseases, myxedema, Lyme disease, neuromuscular disorders, AV junction ablation, ankylosing spondylitis, Ritter syndrome. And then now this is another case. A female presents with syncopal attacks. She was poorly controlled diabetic, sustained anterior wall MI 1 year ago. This is her ECG. What does this show? Whenever you see an ECG, try to see the complete P, Q, R, S, T, what is happening. In addition to the rate, you find out this is a slow heart rate. Now what has happened to the P, Q, R, S, T? Are they in their normal order or not? No. So you see the P waves have their own rate going on. QRS has own rate. This is called third degree heart block or complete AV dissociation. All impulses which are generated at the SA node fail to cross the AV node. So first degree heart block is they all cross. Second degree heart block, some of them cross. Third degree heart block, none of them crosses. So there is total AV dissociation. No relationship between P waves and the QRS. Relatively constant PP interval and RR intervals. Greater number of P waves than QRS complexes. So this is, you identify this is a third degree heart block. The PP intervals are normal, same, fixed. The RR intervals are fixed. But the PR intervals are not fixed. There are more P waves than QRS complexes. This is third degree heart block. No beat generated, SA node reaches the ventricles. There is fatigue, dizziness, lightheadedness. With structural heart disease, patient may have heart failure, weakness, chest pain, confusion, and syncope. So this may be the presentation. Patients might have congenital heart blocks and acquired heart blocks. So these are different reasons. Drugs which can cause it, pathological conditions, ischemic heart disease, cardiac surgery and ablation. The patient may have congenital heart blocks. How would you differentiate between a congenital heart block and an acquired heart block? The congenital heart blocks are present from childhood. But sometimes you may not have the record what has been going on in the childhood or the adulthood of a person. The congenital heart blocks, they are usually asymptomatic. They do not produce symptoms. So if you got symptoms, this may be an acquired heart block. Now I've got bundle branch blocks. We go beyond the AV node now. You got bundle branch blocks and then you got fascicular blocks. Right bundle branch block, QRS is more than 120 milliseconds. This is first requirement for the bundle branch block, or either left or right. The QRS is more than 120 milliseconds or 3 small squares, bigger than 3 small squares. You call it a bundle branch block. You may have a right bundle branch block, you may have a left bundle branch block. Now, in right bundle branch block, if you see the lead V1, you will have an M pattern of QRS. You will have like this. It's a positive complex. They call it the ears of the rabbit. V1 and V2 show RSR dash patterns. So there are 2 R waves. There may be 2 R waves. So this is seen in V1 and V2. Leads 1 and V6 show broader S wave than R wave. S wave is broader than 40 milliseconds. You don't need to remember this one. Keep your life simple. If there is a broad complex, V1 shows an upward deflection. This is right bundle branch block. Lead V1 shows prolonged R wave peak time, that is ventricular activation time of 50 milliseconds or more, while this is normal in V5 and V6. So it's easy to remember, it's difficult to remember. I know you will confuse between left and right bundle branch blocks with these following criteria, which are lead 1 shows this much. So just remember, in chest lead V1, if there is a broad complex and it shows an upward deflection, QRS complex is positive. This is right bundle branch block. This is an ECG of right bundle branch block. You can see it's broad and it's mainly upward. You can see R-R pattern, RSR pattern there. You got left bundle branch block. Again, QRS is more than 3 small squares. V1 shows a downward complex, a negative complex. This is left bundle branch block. Okay? So V1 is important. There are only 2 criteria you remember. As complex is broad, more than 3 small squares. V1, it shows upward. This is right bundle branch block. It shows downwards. It's left bundle branch block. And then you come back with what happens to S wave in V1, what happens to the R wave, Q wave, what happens to the ventricular activation time. So you see, ventricular activation time was more in V1 in right bundle branch block. In left bundle branch block, the ventricular activation time is more on the lateral side of the chest, that is the V1, V5 and V6. So this is left bundle branch block. You can see the complexes are downward in V1. Fascicular block. Which bundle has fascicles? Bundle branch. Left bundle branch has 2 fascicles, anterior fascicle and posterior fascicle. The right bundle branch is only 1 branch. The left one divides further into the anterior fascicle and the posterior fascicle. So if you've got anterior hemiblock, there is left axis deviation. If the complexes are broad, maybe 10 milliseconds, 100 milliseconds, or 2.5 small squares, and there is left axis deviation, this is left anterior hemiblock. So you just forget all these things. Then posterior hemiblock, if there is right axis deviation. If the complexes are broad, there is right axis deviation. This is posterior hemiblock. Now, why these hemiblocks are important to remember? If the patient has bifascicular block, that is the right bundle branch block is present, or left anterior or posterior hemiblock also gets blocked, then you've got only one fascicle which is transmitting. There is block in the right bundle, there is block, for example, in the anterior fascicle of the left bundle. It means only the posterior fascicle is conducting now. So if that is also blocked, that means you got a complete heart block. Now this is bifascicular block. Right bundle branch block with left axis deviation, this is anterior fascicle block. Right bundle with right axis deviation, this is posterior fascicular block. So these are bifascicular blocks. Now which block is this? In the ECG, what do you see? There is a right bundle branch block. V1 is showing an upward, a broad complex. This is right bundle branch block. Now what is the axis? Look at 1, limb lead 1. Complexes are downward. That means right axis. 1 upward is left axis, is downwards right axis. So it's downward, it means this is bifascicular block, right bundle branch block plus posterior fascicular block. The posterior fascicle is blocked. Anterior fascicle blocks produces left axis deviation. So there is right axis deviation. This is V1. Now what labs may be required if the patient has blocks? You may need electrolytes, arterial blood gases, metabolic acidosis can produce various type of blocks, drugs, ischemic heart disease, thyroid studies. Do thyroid studies, they cause heart block? Which thyroid disease will be causing it? Hypothyroidism. Hyperthyroidism causes tachycardia, won't be causing blocks. Connective tissue disorders, Lyme disease evaluation, so you go for all this evaluation. Imaging, you require ECG, EP studies, echo, PET scanning. PET scanning, what does PET scanning show? Inflammatory disorders, some of the infiltrations may be seen on PET, for example, if there are metastatic deposits. MR, cardiac MR, what's the treatment? Activity restriction, atropine, isoproteinorol, vasopressor may be used for short term. Correct the reversible factors, transcutaneous temporary or permanent pacing, depending upon the patient's condition. If it is a temporary condition, for example, the heart block is because of the overdose or toxicity of the beta blockers, you may put in a temporary pacemaker. When the beta blockers are removed from the circulation, the block starts reversing. So you may need a temporary pacemaker or you may need a permanent pacemaker depending upon the patient's condition. Pacemaker can be ventricular or it can be dual chamber. That pacemaker is placed only in the ventricle, or one pacemaker is placed in the atrium, the other one is in the ventricle. So it's called dual chamber. So this dual chamber will be close to the normal physiological electrical conduction. So you can use, now most of the time we use the dual chamber. We can also use single chamber if it's not available, but we generally tend to prefer the dual chamber pacing.